Well, hello, everybody. I am Dr. John Fraterelli, and I'm here with Dr. Anat Carmon and Dr. Emily Goulet from the Fertility Institute of Hawaii. This is Endometriosis Month, and so our topic today is endometriosis. It's a very diverse topic, and so it's not only for infertility patients, it's for patients who have some other symptoms associated with endometriosis, which we will get into and discuss. It's also very common. Approximately 10% of reproductive age women probably have endometriosis. Much higher incidence in the infertile population. And so I guess, with that lead in, I'll ask either Dr. Carmon or Dr. Goulet if either one of them want to comment on, what exactly is endometriosis.
So endometriosis is when the endometrial stroma and glands, that's the lining that's on the inside of the uterine cavity, grows in places it's not supposed to grow. Is typically the part that your body sheds at the end of every month when you have your menstrual cycle. But when it's growing on other places, common places for it to grow are on top of the uterus or in the ovaries. When you have your bleed, it can also cause a lot of bleeding and inflammation in those areas as well.
Yeah. Anything to add, Dr. Carmon?
Well, I have a lot of things to add. I was going to let you guys, but
yeah. So I guess what's my then the next question? Maybe get a little bit more scientific. Any insight into what the etiology for it might be, as far as some of the other thoughts associated with how people get endometriosis?
Yeah. So the interesting thing is that there are a couple theories about this. And I'm glad you asked this question.
That's the problem. They're theories, right?
We don't really know. Yeah, so there are a couple different theories. We don't know for sure, but one of the theories is actually retrograde menstruation. So the thought is that for whatever reason, some people will actually, menstruate and the blood goes out the uterus through the vagina. However, for everybody, there's some degree of retrograde menstruation where some of that blood and tissue flows backwards through the fallopian tubes and is going to end up in your pelvis. That's pretty normal for everybody. But for some people, for whatever reason, people with endometriosis, the tissue has an abnormality where it will actually implant in those areas. So retrograde menstruation is one thought. There's another thought that these lesions actually arise de novo. In other words, that they actually just, for whatever reason, arise within the pelvis, and that it's not due to retrograde menstruation. The thing that people don't really understand, again, is why everybody has these types of risk factors, right? Everybody has retrograde menstruation, everybody has endometrial tissue, but why some people will end up with endometriosis and others won't.
But there are risk factors for endometriosis. One of the biggest risk factors is a family history of endometriosis. So if your mom had it or your sister had it and they had infertility issues because of it, chances are that might also be a factor in your situation as well.
Right, so that does say that there's some kind of genetic component to it, although we're not really certain what that gene is or where it's located at this point, correct?
Correct. One interesting thing to note, though, is that endometriosis doesn't discriminate. It affects all ethnicities and races equally. And a little bit of trivia, it's been found on every organ except the spleen. So it's even though it's most commonly found in the lower area of the pelvis, maybe on top of the bladder or the bowel even, it's also been found on the lungs, on the brain, and there are case reports of endometriosis in men, which is really interesting.
I think we have some questions here. So how likely are you to get pregnant with endometriosis is one question.
We are going to talk about fertility and endometriosis here in a second. Do we want to wait till we talk about that and what some of the causes
Yeah, sure.
for-
We can definitely wait with that. There's somebody else asking about Mirena IUD after excision surgery in order to prevent or reduce further growth. We'll get into that with kind of
the treatments, right?
Yeah, there are a number of different options to control endometriosis. Yeah.
So what are some of the symptoms that patients will have with endometriosis?
So the main symptom that is kind of classic for endometriosis is dysmenorrhea or pain related to menses. Some people will also describe having heavy menses with endometriosis. That's kind of goes along with it, but really the classic factor is is pelvic pain that occurs around the time of menses. If endometriosis worsens and people develop significant kind of scarring, then it can become more of a constant pain. So people with endometriosis may experience pain without their menses as well, but it will usually kind of worsen around the time of menses.
And going to what Dr. Goulet's comment a second ago about endometriosis being found everywhere except for the spleen, depending on where it's found, it's going to cause the symptoms related to that environment as well, right? And so I guess as you said, the most common place is the peritoneum, so the peritoneal cavity, the lining of our internal organs, and then ovaries, very common for women. We'll see endometriomas, right? We'll see big cysts on the ovaries. So, and I guess getting into fertility, why does it cause fertility issues? Or does it cause fertility issues?
Yeah, I think that there are a few different ways that it seems to impact fertility. Again, the classic way that it will impact fertility is by blocking fallopian tubes. That's, I think, the easiest way to understand, because what ends up happening is as you have these lesions, you have blood, you have a lot of inflammation there, and that can kind of cause a buildup of scarring. Typically, it's around the pelvis that can actually scar the fallopian tubes, and then the tubes won't function properly. But it certainly does impact fertility in a number of other ways. Another way is that if you have endometriosis within the ovaries, you can have some damage to the underlying ovarian tissue there, and it can cause issues of diminished ovarian reserve.
And egg quality, that irritative, inflammatory environment can make it more difficult, even if you are going through fertility treatment.
Right. And I'll often have patients who have just kind of a mild or moderate endometriosis, where the tubes are normal, there's nothing on the ovaries, everything looks very normal, but yet they're still not getting pregnant. And there's a lot of evidence with endometriosis, and because it's an inflammatory reaction, right, in the abdomen. And so it's those inflammatory mediators, the cytokines, the helper cells. Those have been found to be not necessarily toxic, but that's the best way to describe it, to the egg as it comes out, and to the sperm, and even to the endometrium, the environment endometrium. There's also been with endometriosis found to have, with patients with endometriosis, when you look at progesterone receptors in the uterus, they have lower progesterone receptors, and that would suggest potentially a lower implantation rate for patients if they do have a fertilized embryo. So there's a lot of things that are underlying that we really don't see, but we do know that they cause fertility. And likewise, people have significant disease and they get pregnant very easily too. So it's not something that's black or white that we say this it causes it or it doesn't. There's a lot of gray in the diagnosis and symptoms.
Right. There are a number of different organizations that have attempted to create, big stages, right? ASRM has stages for endometriosis, and those are helpful when you're trying to describe endometriosis surgically, but not very helpful when you're trying to really understand how that endometriosis is going to affect pain, especially in future fertility, because some people we do surgery for some other reason. We see like, oh my gosh, this patient's just covered in endometriosis and the patients didn't even realize. Other patients have very significant pelvic pain and we look and maybe they really just have a spot. So there really isn't a great correlation between the severity of the disease and pain. Some correlation with fertility, but really kind of a very nebulous one, I think. It's not a great way. We still have a lot to learn about fertility and endometriosis. Thankfully, there are great treatments, I think, for pain, and a lot of them require the ovaries to be suppressed, and so they don't necessarily allow for fertility at the same time. Unfortunately, that's something that as fertility docs we do struggle with treatment. Sorry if I took you guys off course. What's next, Dr. Fraterelli?
No, that was excellent. That was excellent. I guess, how do we diagnose it? How do we diagnose endometriosis?
Well, classically, it's diagnosed with a histopathologic diagnosis, which requires a surgery, typically a laparoscopy. Now, that being said, a picture's worth 1,000 words. So if another doctor did a laparoscopy and took pictures of the gunpowder marks that are inside the abdomen, I'm going to believe that's endometriosis. And not everybody needs a surgery to diagnose it. Many individuals will have classic ultrasound findings. This ground glass endometriomas inside both of their ovaries are pretty specific for endometriosis. That being said, sometimes it can be hard to diagnose endometriosis without a surgical or a histologic diagnosis, but we don't necessarily have to have proof of it in order to treat it. So a lot of patients are treated empirically. If you have a classic history of this cyclical menstrual pain, if you have a history of families who've had endometriosis, if you've had issues with infertility, I mean, if it walks like a duck, talks like a duck, and sounds like a duck, it's a duck. So we'll go ahead and treat it.
Yeah, I think it definitely depends on what the goals are. Many times the initial treatments for endometriosis, especially when we're talking about pain, but the treatments are relatively benign. So sometimes people who will have some cyclic pelvic pain, a really good first step is to utilize birth control pills to suppress the ovaries. And if that treats the pain, well, then, we don't necessarily need to go in and do a very interventional type of surgery in order to determine if there's endometriosis or not. But, if typical first-line therapies are not working, then surgical diagnosis and management might make sense. With fertility, it's interesting because as reproductive endocrinologists, the way that we used to do things was to diagnose everybody, to do laparoscopy on everybody in order to determine if there was endometriosis there. But what we discovered is that the initial, again, treatments for infertility with endometriosis or infertility for other reasons doesn't differ all that much. And so if we discover that somebody has endometriosis, well, we may still recommend them doing superovulation, IUI, and if that's unsuccessful, then IVF. And so discovering that they have endometriosis won't make much of a difference in those early steps. We may make some changes in terms of IVF protocols and the details in which how we might treat people. But I think that just initially it doesn't really make much sense to just kind of do surgery on everyone in order to prove that they have endometriosis.
Yeah, no, I agree. I mean, you guys are, a lot younger than I am, but, in my training, part of the infertility evaluation was, a laparoscopy. Obviously, we don't do that anymore, but now we have ultrasounds that are so good and other diagnostic technologies that we can use that we don't necessarily need to diagnose it every time. I think the one thing is that in Hawaii, though, that we have to realize is that one of the treatment options or one of the diagnosis options that patients can have in order to have IVF potentially covered if you meet criteria is endometriosis. but it has to be something surgically diagnosed. It can't be something that we're just kind of we're clinically diagnosing. Although certainly most or a lot of endometriosis can be clinically diagnosed, especially if we see a big endometrioma. The insurance still doesn't consider that a diagnosis, unfortunately. So we have to look for other reasons, and ultimately we don't want to do a laparoscopy just to get a diagnosis. That's not something that we ever want to do. We really just do laparoscopies these days for patients who have pain. And I guess going in that direction, what about if someone does have an ovarian mass, an ovarian endometrioma? And so when would you operate on that? You mentioned surgery earlier as a treatment option. So we're going to talk about now either medical or surgery. But when would you operate on a mass on an ovary that you thought was an endometrioma?
Yeah, so that's actually changed as well. Us being super young, and that this has certainly changed over the last few years. But
that's why you don't let me sit in the room with you, right? Because that's the young room.
Yeah, this is like I think for the young. Yes. So we used to recommend removing endometriomas in the thought that may improve response to IVF, for example, because oftentimes we do try to suppress the ovaries or get cysts out of the way prior to doing IVF. But with endometriosis, the risk kind of outweighs the benefit. So it does appear that removing endometriomas does pose risk to damaging the underlying ovarian tissue and diminishing the ovarian reserve somewhat. And so literature does suggest that people don't do better if you remove an endometrioma prior to an IVF cycle. There are some caveats to that. I mean, first off, you have to be sure that, or relatively certain that this is an endometrioma and not some type of malignant cancerous lesion. So if you see something and you're unsure if it's large and it's growing very quickly, then that's something that you may want to remove because you're concerned about what it actually is. And obviously we always worry about safety first. But if you're relatively sure this is an endometrioma, especially under 5 centimeters, the literature does suggest that leaving it alone is important. The other caveat is that large endometriomas can cause a lot of pain. And so if the patient's in a lot of pain, you're going to make it worse with an IVF cycle. And so oftentimes removing that endometrioma prior to an IVF cycle, prior to patients achieving pregnancy as well, definitely makes sense.
Right. There are still...
Go ahead, Dr. Goulet.
Well, I was going to say there are still circumstances when surgery can and should be considered, even though it's not our go-to primarily. For individuals who have failed an IVF cycle, or for individuals who are unresponsive to treatment or who have severe pain, surgery is often a good idea so that we can fulgurate and ablate the endometriosis implants. Sometimes there are findings, for example, if the endometriosis has caused severe damage to the tubes and caused hydrosalpinx that are very large, we'll want to take out those tubes prior to an IVF treatment to prevent those inflammatory fluids from affecting implantation and affecting miscarriage rates. So there are circumstances when your doctor will talk to you that they think that surgery might be a good direction to go.
There are two. Sorry.
Okay. So, and just to kind of reiterate what Dr. Carmon said, for ovarian masses or what you think is an endometrioma, I mean, the literature suggests that if you remove them, you're not improving somebody's fertility. In fact, you can decrease it, because if you look at AMH levels before the surgery and after the surgery, AMH level actually decreases. And AMH is the anti-Mullerian hormone level that we look at. And AMH is made from the granulosa cells that surround the egg. It kind of tells you about the quality and quantity of the oocytes. So by removing endometrioma, you actually are removing some healthy tissue probably as well. And so in general, we don't remove endometriomas prior to IVF cycle or fertility treatment, unless somebody's having, I guess that kind of gets into it. The other aspect of endometriosis that we have to talk about when you look at treatment there's two roads, right? You either go down pain treatment or you go down fertility, depending on what patients have. So maybe we should kind of talk about that. And Dr. Goulet kind of did allude to that. So surgery, if somebody's having pain, is certainly something that you want to take care of. And I guess Dr. Carmone was going to say something about, I think the randomized controlled trials that were done. Were you sure we had about to mention?
Yeah, I was just about to mention that there are kind of these two famous randomized control trials and kind of meta-analysis that looked at natural fecundity, so natural spontaneous pregnancy after surgical treatment of endometriosis, and looking at just fulgurating, right? So treating.
Yeah, just to clarify, it was minimal and moderate disease, so not the significant, not the severe.
Correct.
Yeah, right.
Minimal, moderate disease, and they randomized to like treatment or no treatment, meaning surgical therapy, right? I think one of the studies also gave the option for Lupron afterwards, but what they found is a very small increase. If you kind of combine the two studies, a very small increase in natural fertility. This wasn't IVF. This was natural fertility after treatment of mild to moderate disease. And so we do have a lot of patients kind of ask about that and ask about, well, what if I'm not getting pregnant? I have infertility. What if we try surgery, instead of doing IVF, right? And so the truth is that the number needed to treat is very high. So we have to treat a whole lot of people in order to benefit even one person. Okay, so the idea, I guess the take-home point is that it's not a very effective therapy, but therapy like in vitro fertilization for infertility in particular, obviously not for pain we're talking about, is going to be more effective than first-line surgical therapy. Again, if people are unsuccessful, if they're failing, if they've tried other things, none of this stuff is off the table. It's really just a matter of what is standard of care and kind of first-line therapy at this point. But yeah, segue into treating pain and the
first-line therapies.
Well, and I guess just to kind of comment on that too. Sorry, just the if someone comes in and they're asking about doing surgery rather than IVF, I mean, certainly we're going to give them all of the data, and then if they still want to do surgery because they don't want to do IVF, then certainly that's something that we'll consider and offer them if we think it is endometriosis. We just want to point out what the best chances are. Obviously, IVF, you don't have to undergo surgery, and there's risk with surgery that people may not always understand. So certainly we always do that. But certainly, if somebody wants surgery and doesn't want to do IVF, then we will definitely entertain that and do that for them.
Yeah.
Go, Dr. Clay, what were you about to say?
Well, segueing into first-line therapies, Dr. Carmone had mentioned one of the most common ones are oral contraceptive pills, hormonal suppression. We know that these implants are hormonally responsive, and that they even make some of their own hormones so that they are self-feeding. But the idea is if we can suppress the hormonal environment altogether, suppress the menstruation and the withdrawal bleeds, we should be able to reduce the inflammation and the pain that is feeding everything. So one of the most common first-line therapies is often oral contraceptive pills. Now that does preclude fertility treatment, but this is in regards to pain, to managing pain. There are other types of hormonal suppression that we talk about too, whether that just be a progestin alone, such as agestin, a levonorgestrel IUD, which is often, it's been demonstrated to be quite efficacious. Unfortunately, these hormone suppression types don't always work for everybody. There are treatments that's been used for decades is something called Lupron or leuprolide acetate, and it puts a woman into a medical menopause. So from the brain down, it suppresses all of the hormone production. Endometriosis, atrophy, and less in their disease burden. It's really exciting right now. Can you guys hear me? Feedback?
It's kind of going in and out. Yes.
Okay.
I wonder if, I don't know if it's because you need to be closer or it's just an internet issue because of all the rain. I don't know.
Okay. Well, I think what I wanted to get into, though, also wrapping up Lupron. Lupron is an injection that you take on a monthly to every 3-month basis. It's not recommended for long-term management because that entire suppression of all the hormones, the sex hormones for long durations of time can affect bone health. So if you're considering doing Lupron, talk to your doctor about add-back therapy to help reduce the side effects of the medical menopause and to help maintain bone health. But recently, there's been a new medication on the market that I think is very promising. It's a medication, the generic name is Elagolix, brand name Orilissa, that I guess time will tell, but right now I think that there have been some individuals who have found relief using this oral medication who were unable to find relief using the more traditional first-line methods.
Obviously, as all of these suppress the ovaries, and so with fertility, we will typically do other types of treatments of fertility treatment, but we will often utilize these medications during IVF cycles. So for example, for a patient with endometriosis, we may do a stimulation, make embryos, and then we might actually suggest suppressing the ovaries for a little bit of time, maybe somewhere like 2 to 3 months instead of the typical shorter amount of time that we suppress the ovaries prior to frozen embryo transfer. For patients with severe endometriosis or adenomyosis, which talked about, we might recommend utilizing Lupron, just as Dr. Goulet was discussing, for a few months as well, really to suppress the endometriosis and inflammation prior to a transfer. So we do try to keep in mind the endometriosis and personalize the treatment plan for patients at that time. In terms of treatments that are friendly for fertility, that's really that's the tough one, because really the mainstay of treatment is suppressing. So we're talking surgery, right? Which, you can do surgery and then get pregnant after that. In terms of medications, the NSAIDs, right? So things like ibuprofen during your menses, of course. And that's kind of the limit in terms of medical treatments at this point for endometriosis that are really consistent with being able to conceive spontaneously. Letrozole, I suppose, but letrozole, which typically is, again, utilized with birth control pills, right? So letrozole is an aromatase inhibitor, which will drop the estrogen level and will also, if you take it along with birth control pills, will suppress the estrogen, which is one of the things that will typically kind of cause these lesions to grow. And so that can be a very profound and excellent therapy for people who are having a hard time just on birth control pills. But so sometimes keeping that in mind in patients who are undergoing ovulation induction and have endometriosis, we might, opt to utilize letrozole because, perhaps that's not going to have as much of a stimulating effect on endometriotic lesions compared with, say, other types of, either Clomid or FSH, although I don't think that this has really been well studied.
No, that I agree. There's lots of treatment out there, and there's, in our questions or our chat area, there's been some comments. May use Depo-Provera, and some people have been. I guess one patient was recommended that potentially a hysterectomy would be needed, and certainly that is kind of the end of the road right there. As far as the one treatment for endometriosis is, cutting off the food supply, and that's the estrogen that's being produced by the ovaries. And but sometimes it's leaving the ovaries behind and just taking out the uterus will help it too if it's more of a uterine type pain rather than systemic endometriosis. And as Dr. Goulet mentioned, that's giving you Lupron is really kind of shutting down the ovaries as well. as a way of seeing if potentially hysterectomy would be beneficial or not. Because you can't take Lupron forever, right? There's a limit to how much Lupron you can take. Typically, 6 months of Lupron. You can go to a year if you use AdBac, and really counseling the patients and looking at BMI. And very rarely can you do anything more than that. And then some of these treatments, even though we say they're for pain, we use them for fertility as well. I think Dr. Carmel mentioned this. We use birth control pills all the time for fertility patients to downregulate the ovaries and get the cohort of the follicles synchronized. We'll use Lupron prior to a transfer for a patient to really suppress the ovaries in order to improve implantation rates and pregnancy rates for patients. So we do find that a lot of these agents we can utilize, but you're just not going to get pregnant while you're on them. And, so you have to be off of them in order to get pregnant, obviously.
The other thing to talk about briefly would be adenomyosis as well, which I think is also adenomyosis is endometriosis within the wall of the uterus. So the endometrial glands typically are lined. They're kind of in the uterine cavity, but if you have those glands inappropriately growing within the wall of the uterus, that's going to cause a lot of pain and can cause some issues as well. It can be more of a diffuse adenomyosis type where the entire uterus will be quite globular in appearance, and that can cause issues with pain, cramping, a lot of cramping with periods, heavy bleeding, and issues with fertility. Or you can also have adenomyomas, which appear similar to fibroids. So they're kind of benign, non-cancerous lesions that are discrete and grow within the uterus. The problem is that they're actually harder to manage and deal with than fibroids. Whereas with fibroids, we can usually, if we have to, remove them surgically and they come out. There's a very nice capsule and they come out really easily. With adenomyomas, they often don't come out quite as easily. It's difficult to reapproximate the normal myometrial tissue, the normal uterine muscle, and it can be difficult to treat medically as well. So, and this can also impact implantation and fertility. And oftentimes we'll also see patients will have abnormal endometrial linings when they do have this type of presentation. And so I don't know if you guys have any good ideas or advice for me and my patients with adenomyosis, what I should do next. Let's figure that one out.
No, that's a tough one. If you use birth control pills, use Lupron, if they still can't get the lining still can't get appropriate, you still can't get implantation to occur, then ultimately sometimes you have to use a gestational carrier or surrogate, unfortunately. But hopefully, that's luckily very rare because a lot of patients do have adenomyosis and still have good pregnancy rates, although it is lower than someone who doesn't have adenomyosis. There's also a comment on here which we unless I didn't hear you guys, we completely forgot to mention about pregnancy, and it's that's what we're trying to do, right? And pregnancy and its ability to help with patients with endometriosis. So I wonder if you guys could explain how that happens.
It's the best treatment for endometriosis. It's actually a bit of a paradox because we know that pregnancy is actually a very high state of estrogen and progesterone, but for reasons that we don't fully understand, we do find a protective benefit with pregnancy. Not that we all have control in our life when we are ready to get pregnant and when it's time to get pregnant, but certainly individuals who have babies earlier in their life, if they have endometriosis, are able to benefit in several different ways. First off, they don't have the cumulative damaging effects that endometriosis can cause over time. And so I think a lot of us are the type where we try to avoid medications, we try to avoid pills, we just try and get through the pain. And I think this is one of those circumstances where if you have a diagnosis of endometriosis early on, it might be better to go ahead and take those birth control pills until you are ready for childbearing, just in an effort to reduce that inflammation, certainly help with the pain, but it might offer some protective benefit versus letting endometriosis go on its own uncontrolled. Sorry, I took a segue there from from your question about pregnancy, but
no, that was great. We actually had another question about using bioidentical hormone therapy. Any comments on that?
Well, it appears, I mean, again, the mainstay of treatment really is, fortunately or unfortunately, to suppress the ovaries. And so bioidentical hormone therapy right now is made for and not really made to suppress the ovaries. And so if you use bioidentical hormones, which then help you get pregnant, I suppose if you're using estradiol and progesterone and all the stuff we give, you get pregnant, then the pregnancy is going to help with endometriosis. But what you need is something that's going to suppress the ovaries, which is not bioidentical.
Well, I guess you could the bioidentical progesterone. I think that's really the only thing that's bioidentical that we really would think would help with endometriosis. But and certainly it is a therapy that we use. We use progesterone. Patients who are progesterone is one of the options that we'll give patients. It may not be the best option, but it definitely is an option. And everyone, the other thing is everyone's different. Everyone reacts differently to different medicines. And so for some patients, the bioidentical hormone progesterone might be the best thing, and for somebody else, it may have no effect. And so that's the other thing that we really kind of realize in medicine when we have these diagnoses. Nothing's classic. Nothing's exactly the way it says in a textbook or the way we think it is. It affects everybody differently. And do you guys have any, closing remarks about endometriosis?
I think it's just it's something that you need to get on top of. It's something that don't be a hero. Don't sort of just suffer in silence. Definitely see a physician if you're having a lot of trouble. It doesn't necessarily have to be a fertility doctor, but an OBGYN, especially if you're having a lot of pain with menses. Definitely, just like Dr. Goulet was saying, consider treatment early on. A lot of the therapies, like just simple birth control pills, is something that you can do safely and continue to take until you're ready for pregnancy, because that's hopefully going to prevent some of the inflammation and long-term scarring that can occur in severe cases of endometriosis.
So I guess I would also add to that, again, just like I just said about it being just an individual, or it affects everybody, differently. You do have to figure out what you want to do, depending on what, where you are in your life as well. I mean, if you have severe endometriosis and a lot of endometriomas, and you're in your 20s, you may want to consider freezing your eggs if you're not ready to have a child yet, because we do see it when patients get into their 30s. Endometriosis, that it's killed the eggs. It's really bad. That doesn't do that for everybody, but we do see that, unfortunately. It's very sad. So I think, it's like Dr. Carmon said, if you're having issues, go see somebody. And it doesn't have to be a reproductive endocrinologist. Your GYN doctor, talk to them, because there's always something that can be done to help potentially, and there's some kind of advice that may be helpful for you.
Yeah. I agree.
And I think that is all we have, unless Dr. Goulet or Dr. Carmon have anything else to say. I think I would thank everybody for coming. It is almost the end of the month, so happy Endometriosis Month. But again, it's endometriosis awareness. So if you need help or have questions, please contact us or contact your primary care doctor or GYN doctor. And please stay safe, everybody.
All right. Thank you guys for joining us. Bye-bye.
Bye.